All right, can you guys hear me? Okay, great. So I'm going to be talking a little bit about principles and techniques of minimally invasive surgery, and thank you guys for inviting me to talk. Do we have my PowerPoint loaded up? So I really enjoy talking about minimally invasive surgery because I always learn a little bit from everyone's experience and everyone's different techniques. So I kind of developed a talk more based on the evidence-based medicine. And so for some of you, I'm going to be preaching to the choir, and some of you will be asking a lot of questions about some of this information. And here we go. So, the concept of minimally invasive surgery has been around for a very long time. In the 60s, we started doing using the microscope and bipolar electrocautery and minimally invasive or microscopic discectomies. And then there's been all kinds of different techniques with the idea of doing what we need to do with less soft tissue disruption and less pain on the patient's end. And so in 1987, the first lap chole was done in France, and within 3 years, 90% were laparoscopic. So there was a rapid adoption of sort of minimally invasive techniques in that surgery. So spine surgery has been a little bit slower to adopt it, but we're getting there. So the advantage to the patients all know the advantages: shorter operative time once the surgeon gains good experience, less blood loss. The complications are often fewer because we have less blood loss and a little more easy to treat. Less postoperative pain, more rapid mobilization, and shorter length of stays. Advantage to the surgeon: you have a simplified postoperative management. After you do your initial sort of ramping up period, these cases can be faster. You have happier patients. They're easier to round on because they have less pain. Some of the complications are easier to manage. And oftentimes the technique is independent of the size of the patient up to a certain degree. And the hospital loves these type of cases because they get the same amount of money for less expense. So the patients who are have a shorter OR time or a shorter length of stay, the hospital still makes the same amount of money. And so, minimally invasive posterior decompression, we think about these for the disc herniations, the stenosis, a stable spondylolisthesis. And so you can do a microdisc, a laminectomy, laminoforaminotomy. Patients often have heard of mild, but basically you're just doing a decompression through a tube, or you're doing endoscopic techniques. And so the idea is, instead of a midline incision and removing the spinous process and lamina, you're doing more of an indirect decompression using the tube and angling the table. So this was in 2013, there was a Cochrane review looking at open versus MIS microdiscectomy. And they did a search of different terms, and they found that MIS may have lower risk of surgical site and other infections and shorter length of stay, but lower rates of leg pain, back pain, and rehospitalization. So they found some statistically significant differences in leg and back pain, but not clinically significant. So this really sort of laid down the gauntlet for spine surgeons who are advocates of MIS to really prove that what they do is better, because no one really wants to do a surgery that is not as good. And so since 2013, there's been lots of studies comparing MIS to open, showing the superiority of minimally invasive. So this is a meta-analysis in 2016 showing lower post-op pain scores. It's 10 minutes longer, which is not clinically significant, lower blood loss, shorter length of stay, and lower reoperation rate. And so if you look at the forest plot, you can see that for pain scores, things sort of favor the minimally invasive techniques. Length of stay definitely favors the minimally invasive techniques. And so we're starting to see through all this research and publications that minimally invasive really has lower blood loss, shorter length of stay, and about 10 to 20 minutes more of operative time, which for some people at bigger institutions with high turnover, 20 minutes isn't very much. If you're at a surgery center, 20 minutes is probably another case for that day. And so the technique is basically using a tube in either a microscope or some sort of camera if you're doing endoscopic, and you're able to see basically your lamina and get down to ligamentum flavum and do your decompression that way. So you can do your ipsilateral decompression, and then you can take let me see. And then you can angle the tube and do your contralateral decompression for a laminectomy. So for a microdisc, a lot of people are doing microscopic microdiscectomies, and so it's just converting a view from a talar retractor or a McCulloch to a tube. And so many people are doing similar things. And this is a patient who had a prior fusion, who had a adjacent level disc herniation, so able to use the tube, sneak in there and remove it, and he did very well. And so this is sort of what you're looking at through the tube. So many people in this room are familiar with this view, whether it's through a tube or using a retractor of some kind. And so it's basically just converting from a midline incision to more of a paramedian incision and using a little more X-ray. I don't think the videos are going to play, but you can see you can get done exactly what you need to get done. And then once you're comfortable with a tubular microdisc, then you just angle the tube and burr under the spinous process, and you can get to the contralateral lateral recess very nicely. And you can often do a really great lateral recess decompression by taking the superior articular process off that from the medial aspect of the canal and really get a nice contralateral decompression by angling your tube and sort of rotating your table a little bit. And so you're going to get a decompression that kind of looks like this. And so from a sagittal perspective, you can see that there was compression sort of digging in the canal there, which has resolved, or something similar to this, that you are really decompressing both of the lateral recesses. And so if you have a patient with stenotic symptoms, neurogenic claudication, it's a really great operation. Posterior interbody fusion. So I can save this for my debate section, which I'm gonna win. And so you can just look at the technique, and basically you're looking at your facet, and you're taking the facet down and getting into the disc base. So this is a view a lot of people are familiar with, whether you're using a retractor or a tube. Many people are comfortable with this technique. And the outcomes are cost effective. And I'll come back to this later. I'll bury the lead. Okay, so anterior lumbar interbody fusion. So there's a lot of people who are very comfortable with this technique, and whether or not you call this MIS because you're doing perc screws in the back, I think it's a form of doing what we need to do, which is removing the disc and doing a nice fusion at the disc level. And then if you do perc screws in the back, it's less soft tissue disruption, or if you do a standalone, it's less soft tissue disruption, less pain, and patients are able to get out of the hospital faster. And some patients are going home the same day. So, going back to the original interbody fusion techniques, I think it's really important to remember that the idea is to restore the disc height and get a nice distraction across the disc base, and you can get indirect foraminal decompression with this. So I think remembering all the tools in your toolbox and the concepts here, I think a lot of the trouble that we got into with the loss of lumbar lordosis was we were kind of getting caught up in the posterior plinth and the excitement with that, and kind of forgetting that we need to restore and how much we can get with an anterior interbody. And so some people are doing this with the OLIF, which is basically taking this view and shrinking it down with long, thin retractors. And so if you're comfortable doing that yourself or a vascular surgeon, the idea is sneaking down to the area through the retroperitoneal space and safely mobilizing the vessels, and then just getting your discectomy and putting in a large cage. Patients with anterior interbody fusion, no one's going to argue that these patients don't have high fusion rates. And then if you're putting in a nice lordotic cage, you're going to get good restoration of lordosis. If you put in a very tall cage in a patient with a lot of spondylosis, you're going to get a lot of indirect decompression. So a lot of the reviews looking at anterior interbody fusion show that, there's really no difference of an A-lift plus posterior instrumentation versus a posterior lateral fusion plus interbody. The fusion rates are both good, and we have similar outcomes, 80% satisfaction, 89% fusion rates. So no one's going to get 100% fusion rates, but 89 is pretty good when it comes to the lumbar spine. And so the major issues with the anterior lumbar are the risk of vascular injury. So if you have a vascular surgeon doing your approach, not that that's going to be any less dangerous, but you just have an expert who can solve problems for you. And then the risk of retrograde ejaculation in men, and that's a really important point with young men who want to have children. You want to talk to them about that, whether or not you should be considering a posterior approach on them. And then lateral interbody fusion, this is a great technique that was talked about yesterday. And it is minimally invasive because it's less soft tissue disruption, but we're able to get down to certain levels above L5 in most patients and have really good outcomes. You can do a really good deformity correction with the lordotic cage. You can do a really good sagittal plane restoration of lumbar lordosis. Previously, the idea was you really have to put BMP in there, but newer studies and newer evidence are showing you can put in bone graft substitutes or some sort of cancellous chips, and you get good fusion rates. The major concern with the interbody fusion are the at the 4-5 level, your femoral plexus. So some people will do a free-running EMG or pre-medicate with Lyrica to try and decrease the risk of nerve palsies or injuries. And the literature for the lateral interbody fusion is not as strong. It's more based on the technique, but there's been a systematic review that looks at all the studies we have. And because so many of the studies are looking at deformity patients and lumbar degenerative patients, the evidence is just good. It's not great because it's not comparing apples to apples. And so, we have really good evidence that you can get a good fusion rate with lower complications, but the heterogeneity of the studies makes conclusions a little more difficult. And then we can see that there's a couple studies looking at cost effectiveness showing for minimally invasive studies that for the lateral approaches, cost savings compared to a traditional open fusion. And then there is one study looking at MIS TLIF versus lateral interbody fusion. And there was no significant difference statistically, but there was a trend in MIS TLIF towards better leg pain, back pain, ODI, and lower complication rates. And there was no difference in fusion. And again, this is likely due to the heterogeneous population undergoing the lateral interbody fusion included in these studies. So if we looked at single level fusion, I'm sure the differences would be very small. And then the risk of non-neurologic complications. So Uribe sent out a survey to surgeons who've done a lot of these, so at least 100 lateral interbody fusions. And so there was 13,000 patients included in this survey, and there was very, very low wound infection rates and low vascular or visceral complications. So surveys aren't great evidence, but I think most people would agree they see these types of results in their practice. Very, very low infection rate. Vascular and visceral complications are very, very rare. So it's a really great surgery, and people are huge fans of it. And if you do a single level or a couple levels and then perc screws in the back, some people might not qualify that as minimally invasive. I sure would, because you're accomplishing what you need to do with less tissue disruption. And so this was spoken about yesterday, the preoperative evaluation, and then the technique as well. So I won't take you through this again. This is what we all look at. And now with our newer techniques of doing the anterior releases, you can get even more of lordosis correction. And the only issue with the lateral approach is that you can't get to L5-1 easily. So once someone figures that out, keeping a patient in a lateral position, being able to sneak down to L5-S1, we're all going to be very happy. And then looking at deformity patients, so you really don't want to do a lateral approach if they have soft bone, large curves, significant sagittal imbalance, or if they're already fused or rigid. Then you're going to be working against stiff bone, and you're probably not going to be able to get the correction that you really wanted. So those patients are probably not going to be able to get sort of any MIS approach. But what's really great about the minimally invasive deformity surgeries is it's really a confluence of a lot of minimally invasive techniques, including lateral and MIS TLIF, and then some perk screws and rods. So it's really a great example of where we've come in minimally invasive surgery and what you can do and where we're going. Thank you.
Thank you very much.